Welcome to the deep dive. If you are joining us right now, it is probably because you have a real curiosity about how things work.
Right.
And today, we are aiming that curiosity right at the human body. Specifically, we are looking at the incredibly delicate, mechanical and resilient systems inside tiny human bodies.
Yeah, infant anatomy is just fascinating.
It really is. So our mission for you today is to take a massive stack of medical notes. Specifically, we're looking at a comprehensive module on pediatric gastrointestinal disorders and turn it into a fascinating exploration of our foundational biology.
And we should mention, we are avoiding the jargon today.
Oh, absolutely. We are going to completely avoid the dense medical jargon. You won't need a medical dictionary for this at all. Instead, we are hunting for those incredible aha moments that show just how much of a mechanical marvel the digestive system really is.
And that foundational aspect is exactly why this material is so valuable for you to understand. You absolutely do not need to be a medical professional or a nursing student to find this captivating. When we study the gastrointestinal health of infants, we aren't just looking at sick babies.
Right. It's bigger than that.
Exactly. We're really looking at the foundational building blocks of human anatomy. We're getting a real-time look at what happens when the microscopic blueprints of fetal development encounter slight structural hiccups.
Yeah.
Understanding these early developmental quirks reveals how our physical structure dictates our lifelong health.
Okay, let's unpack this. Because right out of the gate, the source material paints a picture of doctors acting less like traditional physicians and much more like, well, like mechanics or detectives.
Mechanics is a great word for it.
Think about it. When you have an infant patient, they obviously cannot describe their pain. They can't just point and say, hey, my stomach hurts right here.
No, they just cry.
Right. So how do doctors even begin to figure out what's wrong inside a tiny, silent patient?
It is pure detective work, and it relies heavily on intense visual observation before they even touch the patient.
Like what kind of observation?
Well, a doctor will first look at the child's body position. If a baby is lying relaxed with their arms and legs loose, that tells you one thing.
Sure.
But if they are drawn up into a tight fetal position, with their knees pulled forcefully to their chest, that one visual cue tells you a massive story.
Because they're protecting their belly.
Yes, it immediately suggests severe abdominal pain because pulling the knees up physically relieves tension on the abdominal muscles.
That makes so much sense. You are looking for the physical workarounds the body is instinctively doing.
Precisely.
And once they have observed that posture, they move to listening to the belly. I was amazed by how much information they can get just from a stethoscope.
Oh, auscultation is an art form.
It's not just a silent black box in there. It apparently has a very specific language. Like, if a doctor hears really loud, hyperactive gurgling, what does that actually mean mechanically?
Think of the digestive tract as a series of plumbing pipes. If you hear loud, constant gurgling, this system's working overtime. It's usually trying to aggressively flush something out.
Like a bug.
Exactly. In an infant, that often points to gastroenteritis, which is essentially a common stomach bug, or perhaps a lactose intolerance. The muscles are spasming to move the irritant through the pipes as quickly as possible.
Got it. Now, I was reading through the diagnostic section, and there was a phrase describing a specific sound that really caught my attention.
Which one?
It sounded almost pleasant. The notes called it high-pitched, tinkling rushes.
Oh, yes.
What on earth does a tinkling belly mean?
It might sound musical, but it is actually one of the most profound red flags a doctor can hear.
Really?
Yeah. That high-pitched tinkling sound is highly indicative of a bowel obstruction.
Oh, wow.
To stick with the plumbing analogy, imagine water being forced under immense pressure through a tiny, narrowed, or kinked pipe.
It would whistle or squeak.
Exactly. It creates a higher-pitched squeak or tinkle. It means something is physically blocking the path, and the body is desperately trying to squeeze fluid past it.
Wow. Okay, so loud gurgling is a flush, tinkling is a blockage. But what happens if the doctor listens and hears absolutely nothing?
Dead silence is arguably the most terrifying sound of all.
Worse than the tinkling.
Usually, yes.
Yeah.
If a practitioner listens for 5 full minutes in each quadrant of the abdomen,
5 minutes is a long time in an emergency.
it feels like an eternity. And
Oh.
if they hear nothing, that usually indicates a paralyzed pipe. The medical term is a paralytic ileus.
Meaning it just stopped.
The muscular contractions that push food along have completely stopped. The entire system is shut down.
It is so mechanical, it's literally like listening to the walls of a house to figure out where the plumbing is failing.
It really is.
Imagine trying to diagnose an entire systemic issue just from the specific pitch of a gurgle or the total absence of one. It really sets the stage for how structural these early issues are.
Absolutely.
Which brings us to craniofacial mysteries. I want to talk about cleft lip and palate. The research points out that this happens incredibly early in pregnancy, between the 7th and 12th week.
Yes, that timeline is crucial. The 7th to 12th week is a highly sensitive window. A cleft lip or palate occurs when the tissues that form the roof of the mouth and the upper lip simply fail to fuse together.
And why does that happen?
The risk factors are a complex mix. It's not just one thing. There is often a genetic component, but it's heavily linked to environmental factors during that specific window.
Like what kind of factors?
Things like a lack of folic acid, smoking, or certain medications. And interestingly, demographically, the incidence is notably higher in boys and seen more frequently in Asian, Latino, and Native American populations.
One thing that completely blew my mind was how they actually test for a hidden cleft palate.
The glove finger test.
Yes, a cleft lip is obvious, you can see it, but a cleft palate is a hole in the roof of the mouth, hidden from view. How does a nurse even know it's there on a newborn?
It's a brilliant tactile assessment. A nurse will actually use a gloved finger and place it inside the newborn's mouth to trigger their suck reflex.
Okay.
While the baby is actively sucking on their finger, the nurse is simultaneously feeling along the roof of the mouth for any opening or gap.
That is amazing. They use the baby's own reflex to feel around in the dark, basically.
Exactly.
But why is that hole such a massive emergency? Obviously, you want to fix it, but why is it an immediate crisis?
Because a baby relies entirely on creating a vacuum in their mouth to draw milk from a breast or a bottle.
Oh, of course.
If there is a hole in the roof of their mouth leading to their nasal cavity, that vacuum is physically impossible to achieve. They simply cannot generate the negative pressure.
The air just leaks right through.
Exactly. So the initial intervention isn't about cosmetic surgery. It is an immediate mechanical problem that requires a mechanical solution to keep the child fed.
And the solution I saw mentioned was something called a Haberman bottle.
Yes, the Haberman feeder.
It's this specialized bottle with a giant nipple, and the parent actually controls the flow of milk using their thumb. The parent is manually doing the work of the vacuum the baby can't create.
Precisely. We engineer a workaround. And even after they get the surgery to repair the cleft, which is usually around 2 to 3 months for the lip and 6 to 12 months for the palate, we have to keep engineering workarounds for human instinct.
Right, the arm floaties.
The elbow restraints, yes.
After the surgery, they fit the babies with these soft elbow restraints. They look exactly like little pool floaties.
That's a great way to describe them.
It allows the baby to move their arms around from the shoulder, but it physically prevents them from bending their elbows to reach up and touch their face. So they can't scratch or ruin the surgical repair. It's such a simple, practical fix.
It really is.
Yeah.
You have to mechanically block the baby from doing what their brain is telling them to do, which is touch the sore spot.
Speaking of mechanical blocks, let's pivot to something that sounds absolutely terrifying, pyloric stenosis.
Yes, this is a major one.
From what I understand, this is when the muscle that acts as the gateway between the stomach and the small intestine grows way too thick. It creates a complete roadblock.
What's fascinating here is how dramatic and visible the symptoms are. Because that gateway muscle is so incredibly thick, food literally hits a brick wall.
So it can't go down.
Right. So the infant will feed normally, but right afterward, they will experience forceful projectile vomiting. The food bounces back with immense force because it has nowhere else to go.
And the notes mention that you can actually see the body trying to fight this block.
You can?
You can see visible waves, stomach contractions moving from left to right across the baby's belly right before they vomit. The body is just pushing and pushing against a closed door.
It is incredibly vivid. And aside from seeing those waves, doctors can actually feel the problem.
They can feel the thick muscle.
Yes. Because that muscle is so thickened, a doctor can press on the center of the baby's upper belly, the mid-epigastrium, and physically feel a lump the size and shape of an olive.
The olive sign.
Exactly, the olive sign. It's a highly specific physical marker. And just to note the demographics again, this condition is 4 times more likely to occur in boys than in girls.
A literal olive-sized roadblock in the plumbing. It's wild. But the plumbing doesn't just get blocked, sometimes it folds in on itself. Let's talk about intussusception.
That's a tricky one to visualize.
I really struggled to wrap my head around this one. It's when the bowel telescopes. What does that actually look like?
Imagine a collapsible pirate's telescope.
Okay, I can picture that.
Intussusception is when one section of the intestine slides inside the adjacent section of the intestine, exactly like closing that telescope.
Ouch!
And when this happens, it drags the blood vessels along with it, kinking them and cutting off the blood supply to that part of the gut.
And the symptoms are so specific here. The child will be in intense agony, crying out, but then they're totally fine.
Yes, the pain comes in waves.
Right. And then 15 to 20 minutes later, they are screaming again. It happens in these regular intervals. And eventually, after maybe 12 hours, they start passing what looks like dark red jelly.
Current jelly stools is the classic medical term.
Current jelly stools, a mix of blood and mucus. It sounds like a guaranteed surgical emergency, but how do they actually fix a folded tube inside a tiny body without cutting them open?
This is where the medical intervention is just a brilliant piece of mechanical engineering. Surgery isn't always the first step.
Really? What is?
Instead, doctors often use an air insufflation or a barium enema. They pump air, or a liquid solution, into the bowel from the bottom up.
They just pump air into it.
Exactly. The pneumatic pressure from that air travels up the intestine, pushes against the telescope section, and literally pops the bowel back out into its proper elongated shape.
They use pressure to unfold it.
They're using air pressure to unfold the intestine from the inside.
That is unbelievable. It's exactly like blowing into a deflated, folded balloon to make it pop straight.
It makes perfect sense when you view the body as plumbing.
It really does. Now let's pivot to something you listening have almost certainly heard of, appendicitis.
A classic.
We all know the appendix can get inflamed and need to come out. But what I found amazing in these documents were the strange physical tells the body gives when it's happening.
Appendicitis is truly a masterclass in anatomical connections. The diagnostic signs aren't just about poking the sore spot.
Right, they check everywhere.
First, you do have McBurney's sign, which is severe tenderness at a very specific point in the lower right abdomen, exactly where the appendix sits. But then we have Rovsing's sign.
Yes, this is the one that blew my mind. The doctor presses down firmly on the left side of the baby's belly, but the patient feels the sharp pain on the right side.
It feels like cross wires.
Exactly. How is that possible?
It's actually about pressure displacement. When you press on the left side, you are pushing the gas and fluid inside the large intestine backward.
Oh, I see.
And that pressure wave travels all the way across the abdominal cavity and bumps against that highly inflamed appendix on the right side. It's a chain reaction.
That is so smart.
Then there are signs where the doctor doesn't even touch the belly at all. The appendix sits right on top of certain hip muscles.
The obturator and iliopsoas signs.
Yes. A doctor can trigger immense pain simply by having the patient rotate or extend their right hip. You are just moving the leg. But because the muscle shifts and rubs against the inflamed appendix, it causes a spike of pain.
It's also interconnected. But I did see a massive, crucial warning in the research here regarding appendicitis.
The sudden relief.
Right. What happens if a child has all this intense abdominal pain? They are crying, their hip hurts, and then suddenly the pain completely vanishes and they say they feel fine.
That is not a miracle,
Yeah.
and is not a sign of recovery. It is a massive medical emergency.
Wow.
Sudden relief of pain in this scenario usually means the appendix is ruptured. It popped.
So the pressure's gone.
The pressure inside the appendix that was causing the severe pain has been released, yes. But now, highly infectious, toxic material is spilling freely into the abdominal cavity.
That sounds incredibly dangerous.
It is. The pain will return shortly, and the situation becomes life-threatening very quickly because of the infection.
It's a terrifying false sense of security.
Okay, we've talked about mechanical blocks, folding pipes, and popping valves. Let's shift to how the body actually processes the material going through those pipes: diet, digestion, and systemic links.
Whole different set of mechanics.
Right. I want to start with celiac disease. I hear people talk about gluten allergies all the time, but is celiac just a really bad stomach allergy?
Actually, it's a common misconception to call it an allergy. It is much more severe and systemic than that. It is an immune-mediated disease.
How is that different?
When a susceptible person ingests gluten, which is found in wheat, rye, and barley, their body doesn't just have a histamine reaction. Its immune system mounts a targeted attack on its own small intestine. Specifically, it attacks the villi.
And what exactly are villi? Villi are these tiny, microscopic, finger-like projections that line the walls of the small intestine. Their entire job is to increase the surface area so the body can absorb nutrients from food as it passes by.
Okay, making a lot of contact with the food.
Right. In celiac disease, the immune system actively damages and flattens these villi. It's called villus atrophy.
I picture it like a plush, thick shag carpet. If you spill water on a shag carpet, those tall fibers absorb all of it.
Good visual.
But with celiac, the body comes in and shaves that carpet completely flat, turning it into a smooth hardwood floor. Suddenly, the nutrients just slide right past without being absorbed at all.
That is a perfect analogy. And because of that malabsorption, the symptoms go way beyond a stomachache.
Like what else happens?
You might see foul-smelling stool, sure, but you also see enamel defects on the teeth and significantly delayed physical growth.
Because they aren't getting the nutrients.
The body is literally starving for building blocks. And because it's an immune system malfunction, it often occurs alongside other autoimmune diseases like lupus, rheumatoid arthritis, and diabetes.
Here's where it gets really interesting. GERD, or gastroesophageal reflux disease. As adults, we think of reflux as heartburn. You eat a spicy taco, you take an antacid, it's no big deal.
Right, an annoyance.
But for infants, the research shows GERD looking radically different and honestly much more frightening.
It is entirely different for infants. In babies, GERD is caused by an immature valve between the esophagus and the stomach. It simply isn't tight enough yet to keep liquids down.
So it splashes back up.
Because a baby's anatomy is so incredibly small that acidic reflux doesn't just cause a little heartburn. That acid can easily wash up and aspirate into the lungs, causing chronic pneumonia.
Oh, wow.
It can irritate the tiny airways so severely that the infant might exhibit apnea, where they literally stop breathing for brief periods.
Stopping breathing. That is a far cry from an adult needing a Tums. And I read that babies will intensely arch their backs during or after feeds. They throw their heads back. Why do they do that?
They're instinctively trying to stretch out their esophagus to escape the burning pain of the acid. It's a physical defense mechanism.
That's heartbreaking.
It is. And for severe cases where the valve just won't tighten up as they grow, the intervention is a surgery called a Nissen fundoplication.
And that's where they actually take the top of the stomach and wrap it around the lower esophagus, right?
Yes, exactly.
Like taking a loose rubber band and wrapping it an extra time around a leaky pipe connection to reinforce the seal. Again, purely mechanical reinforcement.
It's all about reinforcing that barrier.
Now, we also have to touch on the classic stomach bugs, gastroenteritis, like rotavirus or norovirus. The big danger here for infants isn't just the vomiting, right?
No, the real danger is how insanely fast they get dehydrated.
And since they can't tell you they are thirsty, how do you even know a baby is dangerously dehydrated?
You have to look for physical signs of volume depletion. One of the most critical is checking their fontanelles, which are the soft spots on the top of a baby's skull.
What happens to them?
If the baby is severely dehydrated, those soft spots will actually sink inward, creating a visible depression. You also look for a lack of tears when they're actively crying.
No tears at all.
Right. The body is conserving water. And you check for poor skin turgor. If you gently pinch the skin, it doesn't snap back immediately.
And the fix is slow and steady. Small sips of an oral replacement solution every 30 minutes to rehydrate without triggering more vomiting.
Yes, ORS is vital. And eventually moving to the brat diet, bananas, rice, applesauce, toast.
But speaking of nutrition, the material also heavily features something called failure to thrive, or FTT.
This is a really complex area.
The clinical definition is a child crossing 2 major percentile lines downward on a growth chart. But what really struck me were the psychological factors listed alongside the physical ones.
If we connect this to the bigger picture, it perfectly illustrates how the gastrointestinal system is inextricably linked to the neurological and psychological systems. They do not operate in isolation.
Right. It mentioned things like anticipatory gagging or intense food fixation.
Yes.
It's not always just a broken pipe or a flat shag carpet. Sometimes the brain and the sensory system are completely resisting the feeding process. It's fascinating that these physical stomach issues often require a multidisciplinary psychological feeding clinic to intervene.
Exactly. The hardware might be fine, but the software running the feeding protocols has a glitch.
That leads us perfectly into the final section, the extremes of development. These are much rarer conditions, but they show what happens when the very early fetal blueprints go severely awry.
Very true.
Let's look at Hirschsprung's disease. This presents as an infant having no meconium, meaning they don't have their first poop in the first 24 hours of life. What is happening in the pipes here?
In Hirschsprung's, it's an electrical failure. There's an absence of ganglionic cells in a segment of the bowel.
Ganglionic cells.
Essentially, the nerve cells that tell the bowel muscles to contract and push stool forward simply didn't develop in that specific section.
Oh, I see.
So the plumbing pipe is physically there and open, but the electrical wiring telling it to squeeze is missing. The stool reaches that dead zone and just stops completely. You often see ribbon-like stool and an empty rectum on a digital exam.
So the body is just missing the wiring. And then we have biliary atresia, which sounds like the body is missing the chemical delivery system.
Yes, that usually presents around 2 weeks of age.
The infant presents with significant jaundice, dark tea-colored urine, and extremely pale stools.
Yes, biliary atresia is a failure of the bile ducts to develop normally. The liver is producing bile, which is essential for breaking down and absorbing fats, but the pipelines to deliver that bile to the intestines were never built.
So the fat just passes through.
Right, and because they can't absorb fats, they can't absorb fat-soluble vitamins. This requires intense intervention like vitamin A, D, E, and K supplementation, and frequently an entirely new liver transplant.
It is staggering how delicate the construction process is. But if you want to talk about extreme fetal development, I have to ask you about omphalocele and gastroschisis.
Those are major anomalies.
When I read about these, I had to stop and reread it 3 times. It sounds like science fiction. You were talking about organs growing on the outside of the baby's body.
It is jarring to visualize, but yes. These are 2 intense developmental conditions where the abdominal wall fails to close properly very early in gestation.
Let's break them down. What is an omphalocele?
With an omphalocele, the infant's stomach, intestines, and sometimes even the liver and spleen grow outside the physical body cavity. However, they are safely contained within a protective translucent sac.
What is the sac made of?
It's made of amnion, peritoneum, and Wharton's jelly. So the organs are outside, but they have a biological shield holding them together.
Okay, so there is a sac protecting them. But what about gastroschisis?
Gastroschisis is an opening, usually just to the right of the umbilical cord. The intestines grow outside the body, but there is no protective sac whatsoever.
None at all?
None. They are completely exposed and floating in the amniotic fluid inside the womb, which can cause severe damage, thickening, and swelling to the delicate intestinal tissue.
I have to pause you there because my brain is having trouble even picturing this. You're saying the baby's intestines are just floating freely in the womb.
Yes.
How does a baby even survive that? And more importantly, how do doctors fix it once they are born? You can't just shove them back inside, right?
You absolutely cannot. The medical intervention is a marvel of patience. For gastroschisis, the moment the baby is born, doctors have to immediately cover those exposed organs with non-adherent, sterile, saline-soaked gauze to keep them moist and protected.
To prevent infection.
Exactly. And because the baby's abdominal cavity is actually too small to hold the swollen organs yet, they use a specialized silo bag.
A silo bag?
They suspend the organs above the baby, using gravity to slowly, millimeter by millimeter, gently guide the intestines back into the abdomen over several days or weeks.
That is incredible.
And during this entire time, the baby is kept alive purely on long-term intravenous nutrition called TPN.
The patience and the pure mechanical precision required are astounding.
It really is a feat of modern medicine.
So what does this all mean? We have journeyed through telescoping bowels, missing electrical wiring, and using air pressure to unkink plumbing.
It means that the human digestive system is far more than a simple tube where food goes in and waste comes out.
Right.
It is an incredibly complex, interconnected network of plumbing, electrical wiring, chemical plants, and immune defense mechanisms. When it malfunctions in infants, it requires intense mechanical detective work because the patient cannot speak.
They have to look for the clues.
Exactly. The doctors must rely on visible waves, the pitch of a gurgle, and tactile feedback to solve the puzzle.
And for you listening, understanding these root mechanical failures helps demystify the human body. It takes terrifying, inexplicable symptoms, a baby throwing their head back, a strange high-pitched sound in the belly, or a sudden scary cessation of pain, and turns them into logical, solvable puzzles.
It proves that there is a profound physical, structural reason behind every single symptom. The body isn't random, it's a machine. And this raises an important question, and it's something I want to leave you to ponder long after we wrap up here.
I love a good final thought.
If so many of these severe, life-altering gastrointestinal issues are caused by microscopic structural misfires that happen in the very first 12 weeks of fetal development,
Yeah.
it raises the question, are the minor, nagging digestive issues we experience every day as adults truly just tied to our diets and lifestyles? Or are they actually the distant, unavoidable echoes of how we were structurally built in the womb?
Wow. Are we just dealing with the plumbing we were built with? That is a wild thought to leave on. Thank you so much for joining us on this journey through the mechanics of the human body. Keep asking questions, keep looking for those hidden connections, and we will catch you on the next deep dive.